Good morning to everyone. See, let me make a confession before I start speaking. Primarily, I'm not here to make a presentation. I'm here to meet my friends. And when Narendra gives a call, no one says no. So I didn't have the audacity to say him no. I said, I'll certainly. Then he added, मैंने कहा मेरे लिए क्या? He said, you have your friends VK, you have Sandeep Bhalla, you have Vivek Desai, you have everyone you need to meet. So he has this capability of bringing all these people under the roof, which probably few people have. I think with so many legends on the dais and in the audience, I feel very humbled to be speaking. This is a very complex topic, about healthcare reforms. So let me start. Sometimes I get worried when people say Indian healthcare system, because the definition of a system and what we see as healthcare in the country doesn't add up to be called a healthcare system in the country. I think those of you who have been from the patient side or even provider side have seen how disconnected, how siloed we are in our approach. So I don't know if you can really call our healthcare as a healthcare system in the country primarily. So I wanted to preempt that first before I move into my main topic. So healthcare reforms looks like a very new topic to people. This is an area of immense interest to me, not just from the point that I wrote the BJP's manifesto, but I have been working on a book on healthcare reforms with Elsevier Reed for close to a year and a half. I have tracked 200 years of healthcare in India, more than 200. So there have been changing goalposts. Healthcare reform has been in India for as old as 19th century. You know when the first Surgeon General of India was appointed in India? Does anyone know? It was 1644, East India Company. We had the first Surgeon General, 370 years ago. So predominantly the first phase of healthcare reforms started happening somewhere around 1859, when we had a Royal Commission. And the Royal Commission was focused. See, the changing goalposts have been because during the 19th century, our focus was on the military, on the Europeans staying in India. So if you see, the focus was on hygiene, sanitation, and mostly confined to cantonments. It didn't go beyond that. So the Royal Commission that started in 1859, that was primarily to give a report on what is the state of healthcare for the army in India. 1863 was another Royal Commission that was on the state of sanitation for military in India. So that was the first phase when we focus on European and the military. Obvious reasons, they need to rule the country, so they need to secure the people who are fighting for it. Then came the next phase. We started off with a huge population, which kept growing. So the focus was on communicable diseases. Around 2000, there has been a global focus. India always follows. It's not a leader in terms of ideas or innovations, it's a follower country. So now the focus has been NCDs and rural health. Now there are interesting angles to how to look at healthcare reforms. Healthcare reforms in India have not happened on their own. So if any leader stands up to take credit saying that India looked at its population and started doing things on its own, it would be wrong. Post-independence, I don't know how many of you are aware of this terminology called SAP, SPRS. See, India as a country always depended on help from foreign countries in terms of finances, whether it was loans from World Bank, whether it was aid. So basically it was aid driven. So typically the developed world, predominantly United States, calls the shots. There's a concept that I've put here, $1, one vote. So on all the major organizations in the world that either grant loans or give aid have the rule of $1, one vote. And we know which country gives maximum aid to those organizations. It's the United States. In fact, yesterday I was in Delhi and the Deputy National Security Advisor had called me. She was visiting India, Caroline Atkinson. And we had a long discussion on what are the points of collaboration between two countries. And finally the discussion boiled on what are the business opportunities. So we know. So they started something called structural adjustment programs. They said, okay, we'll give you aid. You open these sectors. We'll do this for you. You do this for this country. So whatever India did, whether it was health or other sector opening, it was all based on quid pro quo, say you do this, I'll do this. Nothing India could do on its own. SAPs failed. In fact, if you read some of the studies on the politics of global health, SAPs were a disaster. Infant mortality, maternal mortality in some countries like Kenya doubled. As cleverly as they do, they changed the name of SAP to Strategic Poverty Reduction Papers. But the intent and the program remain the same. India has been no different in terms. So see, when we were talking about AIDS, we should be talking about malaria. And those who are enlightened people in healthcare in India, they know our priority wasn't AIDS, it was someone else's. Of course, we implemented, there are results. So clearly, we were under the influence, which was not intrinsic, which was extrinsic. So there is a new beginning. The beginning, and there is a great hope now in the new regime. First thing is the end of planning commission. For those of us who have interacted, we have seen some people have called them as armchair advisors, people sitting in the air-conditioned cabins, talking about rural health. This is a government with the majority. Of course, still a long way to go. We have doctors as a health minister who devised the pulse polio campaign, so he knows how to devise campaigns and implement them and succeed. The policies were written by ordinary Indian like you, so when you read the document, you will find that there are a lot in sync with what you face on a day-to-day basis, not just on health, but every sector that you will read in that. Probably no one can dictate us now. We have a strong leadership, and we understand what we can do on our own. And there's an end of ad hocism. All throughout, if you see healthcare or rather any sector, we have been very ad hoc. So if there is a big focus from the world on infant mortality, maternal mortality, we jump towards it and start a campaign. We came up with National Urban Health Mission, and my friend Colonel Pawan Kapoor was telling me, Brigadier Pawan Kapoor, that Rajan, you had made a statement couple of years back in a program that Urban Health Mission become a victim of infant mortality. It died in 1 year's time. So this is end of ad hocism. So question is, what do we expect in next 5 years? My challenge came when last July, my kind of mentor and my close associate within the BJP, a senior most leader and founder, Dr. Joshi again became the chairman of the manifesto committee. So 2009 I had written the manifesto, but the government, the party had lost the election. So this time they again trusted me to write that. So that was an enormous opportunity, knowing very well the mood of the people, and there could be a change. So the responsibility was immense. But then people like us who pass through the daily grind also know what the country needs. It was not someone politician thrusting his views on saying what needs to be done. So I am putting these two clippings because when I was writing the manifesto, a lot of people who couldn't get into this told me, Rajan, manifesto is like a document. Sab party likhti hai, sab bhul jate hain. Nothing big in it. And I know it was true because every party writes for the years. Working for BJP, I have been dissecting manifestos of the ruling party every year, and no one takes cognizance of what they promised during the election. So I was shocked when the president's speech came, which is normally the outlining of the policies of the new government, covered everything from the manifesto, even include the slogans. And this came in Economic Times. They even quoted my name, which you see here, which was not expected. This was more important. The Cabinet Secretariat has been calling the ministries and telling them that your goals are not aligned to the manifesto, please reject them. So this Prime Minister and that erstwhile party president, Mr. Rajnath Singh, when the manifesto was getting released, he had promised publicly that every word, this is not a Ghoshna Patra, this is a Sankalp Patra. We have a commitment to this public that we will implement every single word written in this document. And trust me, these guys have kept it. So I'm very happy and delighted, these guys are implementing something really great that we can look forward to in the next 5 years. What's in it for health? So I picked up straight from the document. It's nothing that I'm putting it outside, and it is the manifesto's view, not my view. When we were writing the policies of health, last health secretary, when I used to tell him that how you're going to spend 3 lakh crore, we don't have a health policy. The last health policy that came in 2002 didn't have the word chronic diseases, though it mentioned about CVDs and diabetes. And his answer to me was, no one wants to work here. Even if I initiate the work, who will write that? So the first thing I did in the manifesto was write, the first point is, we need to have a health policy. They should show that we should end ad hocism. We should clearly plan out, because see, since 2002 and now, There has been NRHM since 2005. A whole lot of things have changed in the urban areas, rural areas. There have been global developments. Technology has played an integral part in the world. The way insurance is shaping out, we have experience from US, Canada, UK, even smaller countries of what they have done to healthcare. So we definitely need a health policy. You just simply can't allocate funds and expect a finance minister to give you the budget that you want without having a policy. So the first thing is to have a policy. I think the work has already started. July 30 was the date when internally the ministry was working on those 58 topics to develop the policy. All of you who work in health are concerned about it. I would strongly encourage you to write to the ministry if you have views, if you have ideas, because this is the time the policy is getting made. This is the time when you can put forth your views, and if you have data to support that, it will be absolutely great. So the goal of this health, overarching goal was reduce cost, improve quality, and make it accessible. I was a part of the Public Accounts Committee report number 1939, which looked at health in 2010-11, and it had taken views of the health administrators, the secretary and the state, and they had found that NHM had glaringly failed to accomplish what it was meant to be doing. So one of the things is to radically transform National Rural Health Mission into National Health Assurance Mission. The goal is, it's not just insurance, it's not about the financial delivery of health, it's about the delivery of health. So health needs to be assured, and whatever it takes to do should be done. When I was writing the manifesto, I went to my friends in the ministry, and one of the person who is a senior official told me 90% of my time goes in handling MCI. Do something about it. Now MCI is a pain for many bureaucrats, a pain for many medical institutes, and as such for doctors as well. Of course, there were some great ideas that we discussed, but finally we zeroed on to do one thing, and that was that MCI, the whole idea that came from the ministry was Medical Council of India protects the turf of doctors, Nursing Council of India protects the turfs of nurses, and the Pharmacy Council of India protects the turfs of pharmacists. Who takes care of the patients? So the whole idea was to transform into a leaner body that will take care of the entire interest and would have members from all stakeholders, not just doctors or pharmacists or nurses. So I think that work is already going on. Of course, the vision has to be implemented by same bureaucrats, so I am a little skeptical about the final outcome of all these things, but with an enlightened PMO, we hope things will be in place as envisioned. The other big challenge I have seen is, I work across healthcare boards, whether it's pharma or it is clinical hospital boards. Sometimes I have seen where these companies used to come with issues saying, okay, can we talk to the secretary of who looks after pharmaceuticals? Unfortunately, it doesn't get into the Ministry of Health. The Ministry of Health currently is spread across 25 ministries. So predominantly, if I were to name, the biggest program, the Women and Child Development Ministry heads the ICDS. It's around 1.2 lakh 8 crores budget for the 5-year plan. And the pharmaceuticals, which comprise a major cost of healthcare, is under Department of Pharma, under Ministry of Chemicals and Fertilizers. So on the last day of writing the manifesto, I put this, that we will recognize the Ministry of Health and Welfare to converge various departments under Ministry of Health. It's going to be tough. Let me say, because it has been tried in the past, somehow it's not happened, but I think with the majority, this time it can happen. And this will be a big change. It will be big responsibility to the Health Minister and to the Secretary of the Ministry of Health, because then you'll be looking after a much bigger ministry. We have to make India self-sufficient in medical healthcare resources, professionals, so I think there's going to be a change in terms of medical education, the curriculum. So this will happen. Yoga and Ayurveda and Siddha, Unani, whatever you call it as alternative systems today. If you look the history, or if you read the book by Harrison, he has very clearly put it, how British killed the indigenous system. And he went through the research of last 250 years. If you read Bhore Commission report, which I think every doctor has to read probably as a part of curriculum, he didn't even get into this area. He said, this is the area we decided not to get into. And this is the area which is the focus. That's why you see the current health minister making announcements. This will be our priority, to integrate this, give it its due share in the healthcare administration of the country. Of course, one point, because you're all hospital administrators here, if you see this point, this was important. Well, I very much believe We need private sector, to boost the healthcare of this country, because last 66, 67 years, as a government, it has failed to, match up the public expectation. But also, I think there is a need for modernizing government hospitals. There is no reason for us to say, let's only boost private sector, but let's forget the government hospitals. There's a report that we recently did, with 60,000 people across the country, and I was shocked to see the findings, where the perception of the people is that there is no difference almost in terms of private and public in terms of people liking it. And this was done with IHMR, so no questions about the credibility of the report. So focus is going to shift to child health. I made a speech in United Nations some years ago where I said, let's divide urgent and important. The urgent is fix the system, address chronic diseases, but most important is 30 years from now, we don't want our next generation to be talking about these things. So fix child health. So child health programs, I am sure you all know, it started in 1908 in Baroda. But if you go and see today what's happening in child health in schools, it's probably nothing. So I think this has to be a focus area. School health program will be there, which probably needs to go up in a big way. Rural healthcare delivery, we have been talking a lot, I think will be boosted. Senior citizens today account for more than 100 million. There has to be a dedicated program for them. Chronic diseases, Dr. V.K. Singh is here. We both were among the founding members of DMAI. It was formed as a result of what happened in the United States in DMAA, the Disease Management Association of America, where I've served on boards. So chronic disease management programs, which have been lacking in the country, needs to be focused, because you can't just manage chronic diseases on prescription basis. It needs continuous care. Other things that you need to see is, I have always felt, that when we talk of Ministry for Mobile Health and E-Health, the first thing is that let's put ICT. I had in fact kind of discussion when we were holding the daily call to action meeting, and I told our then DGHS, let's put mHealth and telemedicine. He said, let's put ICT. I said, that's very vague. If I put ICTs in this policy document, and that was on behalf of the Ministry of Health, I said, what you would measure after a year or two? You would say an ad given in Doordarshan is a part of ICT campaign. I said, let's put telemedicine, let's put mHealth. Luckily, at that time, we were able to insert this word telemedicine in point 2.12 of the daily call to action document of the ministry. But this time, I decided to put it as an institutional activity. When you create an institution, it's going to be lasting. So in a couple of areas, I have decided, when writing the policy, to create institutions, because that will continuously deliver term after term, year after year, not confined to 5 years. Same thing I did for farmers when we put Organic Farming and Fertilizer Corporation of India to promote organic farming. Same way for e-health, we said we'll start a National E-Health Authority. The goal of the National E-Health Authority would be to use ubiquitous platform of mobiles, use telemedicine to expand the coverage and reach, but also the legal framework is missing. Today, if a doctor wants to use telemedicine and mHealth, which many want to, there is no legal framework. There are no standards. What do you do? And nowhere in the world, where we can, say, okay, we will copy these standards and incorporate. Probably we have to develop something for India. So one of the goals would be to set up the National E-Health Authority and come up with standards for mHealth and e-health. This is the first time that you will see that hygiene and sanitation came under the health part of the manifesto. It was always under urban development or rural development, because these are important determinants outside the medicine and hospitals that determine the health of this country. So this is the time I think there's a commitment to provide by 2022 every household Pakka house, as we call it, with 4 things: electricity, water, toilet, and access. So this will become a part of this program, which I think will get launched on 2nd October. So again, is universalization of medical emergency services, reorientation of herbal plant board, and it was tough, but I think the leadership agreed when we said population stabilization has to be put in the manifesto. That's a sensitive thing, considering various things, and it was BJP, and talking of population stabilization is always viewed as something very different, but we said, okay, that has to be a focus area and has to be pursued in mission mode. Then of course, malnutrition has to be eradicated. We have been doing ICDS for 40 years, we have spent lakhs of crores, but then we again had to launch a Food Security Act, which I don't see a logic for. If 40 years we did this program to eradicate malnutrition, why we need to guarantee a Food Security Act? Probably we failed. So I think there has to be a program to say, let's eradicate malnutrition now. So few constraints which are constant in the healthcare system is the population that keeps rising and the resources that keep going down in terms of percentage because the population keeps rising, and we already have a tight fiscal situation. It's going to last there for at least more than 5 years. If people are expecting things will change in 2 years and 3 years time, probably people are talking about 100 days. I'm pretty surprised. The country had debts of 36 lakh crores, 45.6 lakh crores. Every Indian has a debt of 38,000 rupees. And every year we have to pay 1.9 lakh crore for redemption of bonds that the previous government has promised. There is absolutely no money. So first there has to be opportunity to create investments in the country. Health has to get a focus. It's a big focus area for the government. But if you're expecting things to happen immediately, and one thing I don't see anywhere, probably when people talk is the patients. Patients are missing absolutely in the healthcare system. There is no voice of patients. The doctors are organized, the industry is organized, patients are not. This is something, and the last point I would say is, all of you have a stake, all of you are stakeholders. Don't think that governments will come with the best of ideas and do it. If you feel strongly about something, write to people. The Prime Minister has set up a website where you can communicate with him. The Ministry of Health is open to ideas. This is the time when we all have to work together to transform these ideas that we have put forth into reality. And I'm sure we're going to make it happen. Thank you for patiently hearing me out. Thanks.
Thank you very much. May I now request Dr.
Chairpersons, co-speakers, ladies and gentlemen, I know that we are short of time, and I absolutely understand the need to keep to time or perhaps save some time, which will make everybody here smile, because I know the minister is expected. So I shall be brief. In fact, I can simply say everything that I wanted to say in one sentence. We need to come together, we need to stay together. And if I say that and say thank you, my job is really done. But let us actually look at some of the issues that the Indian healthcare is facing. I'm indeed very, very pleased that the previous speaker, Dr. Gupta, spoke so with such clarity the thoughts of the government. And indeed, that is music to my ears. What we all know is there has been a subtle but certain change in the healthcare industry in India. And the facts that this was related not only to a growth of population, but to others is quite clear. Technology played a very important role in ensuring that the way healthcare is practiced changes. And with this change came increasing costs, and therefore a desire on everyone's part to control it. The payer changed in India from self-pay or government pay to insurance pay, and that is obviously the way of the future. Private healthcare became more important, and the kind of diseases that we had changed from communicable to non-communicable diseases. What also actually happened was that the kind of diseases that the people of India suffered from changed and continues to change very rapidly from the communicable to the non-communicable. For-profit became a not so bad word in healthcare delivery, and because of the rapid growth of the healthcare, not only in terms of availability but also spends, manpower became inadequate, and there was a need for us to look at quickly supplementing manpower at quality within this country. Health, for a change, became a driver of the economy, and consumerism became something that all of us looked at but were not pleased about. Also, there was a rapidly emerging middle class, a middle class that could look at insurance, a self-pay insurance, not the social insurance that the government has so carefully sponsored in this country, but also it had a very, very complexity, a great complexity about it, because it was not one single group, but a number of groups working together. But the middle class really changed the way that health is practiced and will continue to be practiced in this country. It is astounding that the kind of change in the disease pattern, which I've already alluded to, is staring at us in the face. And the problem is that communicable diseases, by and large, could be treated and you're done and over with. However, with non-communicable disease, the cost burden on the country and the patient is substantial. And therefore, you will have to understand that many of these require prolonged and sometimes treatment for life. I draw your attention also to the unfortunate incidence of accidents in this country, which takes lives and creates morbidity of the most unfortunate nature. So, if you look at the healthcare delivery, it's obvious that we have the government and the private setup, and the fact that the private players are becoming more and more important in this entire scene is quite clear. But what is equally clear is that we are disorganized as a group, as an industry. The primary care does not look at secondary, and the secondary at tertiary. A patient with a headache can walk straight into a super specialty hospital and see a neurologist. The sum and substance of this quorum is that we do not have an effective, clear way of healthcare delivery, which is unfortunate. And obviously, the demand versus supply being what it is, we find an abundance of tertiary healthcare facilities in the urban areas and an inadequate amount in the rural and semi-urban areas with its own set of problems. Obviously, the industry is going to grow. It has to grow, it will grow, and will grow fast. What is important is to note also that the government has shifted from being a provider to a player, to a payer, and it is also important to note that anything that we do in terms of scalability or operational efficiencies takes time, and therefore has to be something that is done in an organized fashion. Now, it is obvious, therefore, that aspirations of all stakeholders has considerably changed. In this disorganized sector, and I use that word because it needs to be changed, and with emphasis, what is unfortunate is that there are certain other drags on the wheel that prevents us from moving forward. And firstly, and the most important, I would imagine, is the failure to see the other's point of view. And I'll explain that in a bit of a detail. Consumerism is important, but consumerism in its inadequate or wrong form can be hurtful to the industry and can retard growth. And lastly, and I speak with substantial emphasis on this too, integrity and ethics in the industry. My dear friends, let's face facts. There are people with substantial ethics and integrity in the medical fraternity and in the healthcare space in general. But there are others who unfortunately have prevented appropriate growth of this sector. In all this, therefore, as I said, the discord needs to be changed and certain areas need to be cleaned up. And the discord will be put across in the following examples. For many years, the health insurance people and the healthcare providers would not see each other or sit across the table. Each viewed the other with suspicion, and therefore the net result was the insurer not having a clear understanding of the way a disease is treated or the problems, and vice versa. It is fortunate that the aegis of the IRDA and the others has changed this. And since 2008, there's a much better parlay between these two groups, which enables us to see a better and coordinated effort at healthcare insurance. Imagine a situation where the provider and the insurer, or the payer of any category, sits together and understands how to compensate for healthcare provision. This would create efficiencies of the best kind. The second was a huge mistrust between the government and the private players. The government has attempted, and seriously at that, to look at the PPP model. But that has failed compared to any other industry. And there is only one reason for this, and that is mistrust. it is necessary that this mistrust is shed on both sides, that the government understands that all private players need a for-profit kind of situation, and the private players understand the aspirations of the government and the needs to ensure that there is a social component to everything that we do. And lastly, private players versus private players view and continue to view each other with suspicion, with severe competitiveness, and do not look at anything but hurting each other. Is this good for the industry? The answer is an emphatic no. It drags the industry, it does not see a larger goal, and therefore this needs quick and substantial change. So what I am simply stating is that in the industry there is a need for us to come together. And what will happen when we come together is that there's a synergy of purpose. There is a need for everybody to understand that there is space for everyone. And if there is a coordinated effort between the various players, substantial change can happen. There are many organizations that have now started looking at it. And I speak of various organizations here, of which I am proud to have been a part in one way or the other. Take Nat Health, for example. This organization has every single stakeholder in the healthcare industry coming together. And this will enable discussions and an understanding and hopefully a forward movement in the appropriate direction. But that is not all. There is a need for us to understand how this coming together needs to happen. I spoke of the insurance industry. I spoke of the government and the private player coming together. I spoke of the private player coming together. But the need of the hour, and the very strong one at that, is to ensure that in healthcare at all levels, be it private or at the government, there is an evolution of the gatekeeper concept so that patients can be guided, and that there is a relook at the primary physician, both at the urban and rural areas, in such a manner that this person functions as a gatekeeper like every other primary physician, for example, in the National Health Services, or for that matter, the general practitioner of the earlier years, who can guide the patient to move from one to the other. There is also a need for the government to ensure that licensing is such that it does not permit more than one hospital or healthcare provider to take care of people within a certain radius, and that there is a good and clean method of referral between players who are secondary or primary and players who are tertiary. And finally, my dear friends, the extremely important aspect of accountability, which is very, very dearly required for our industry. I am sure if the joint efforts, the government and the private players, were to work towards this, it will happen. I have faith in the future. Thank you, ladies and gentlemen.
May I now request Dr. Shetty to share his perspectives, please.
And went to bed thinking that it is somebody else's problem, it is not my problem. But believe me, soon it is going to be your problem. It is going to be everyone's problem if nothing is done to prevent it. Every 7th doctor in the US gets sued by a patient. We are very lucky. A lot of us haven't been sued yet. But future is not going to be an extension of the past. We will have large number of litigation against the doctors. We are thinking that we are protected because US has, for every 300 citizens, there is one lawyer. And everyone thinks that US, the litigation against the doctors are very high because they have too many lawyers. And we in India are lucky because we don't have that many lawyers. I'm sorry, Delhi has one lawyer for 300 citizens, exactly the same ratio like US. So if you think that there aren't that many lawyers waiting to sue you, you're mistaken. What is the solution? The solution is we have to press the government, convince them to cap the malpractice compensation. Is it possible? Yes, it is possible. Majority of the US states, you can't sue a doctor for more than $150,000. In US, if they have capped, why not we cap it here? When the government of Cayman Island asked us to build a hospital, one of our criteria, apart from recognizing Indian degree, is that they should cap the malpractice compensation to $250,000, which they agreed with great reluctance. Only way we can protect ourselves is by capping malpractice compensation, because when a patient is unhappy, it is not the patient who is going to sue you. It is a lawyer who will grab the patient file and he is going to dig detail into your the discharge summaries, and he is going to file a case against you. And whatever comes out of it, they will all share with each other. And this is going to be the reality. Why are we so vulnerable? We are vulnerable because our practice pattern is that if you have done everything to save the patient's life, but you have not recorded it, in the court of law, you stand naked. On the contrary, you have done nothing to the patient. You let him die, but you recorded everything that you have done it to save his life. You are protected. 84% of the hospitals, so-called hospitals in this country, are less than 30 beds. They have no medical records department. They do a gallbladder surgery or conduct a hysterectomy, and in a piece of paper they write gallbladder hysterectomy done, and the patient goes home with that. When this patient files a case against you, where are the documents you are going to protect yourself? They simply don't exist. And if this happens, majority of the children of this country are born in these 30-bed nursing homes. And these are the nursing homes where basic health care is provided in small towns. One litigation against one doctor, if he is asked to pay 2 crore rupees for some unfortunate incidents, this doctor sells his house, his nursing home and farmland if he has, he can't come up with 2 crore rupees. That's the end of his profession. And few incidences like this, all the nursing homes in small towns will close. This is what happened 30 years ago in the US, and it is going to happen here. In the US, they had the resources to airlift a pregnant lady to a larger city hospital. We don't even have an ambulance to take the lady. And if we do not take action, believe me, doctors in the small towns will stop practicing. In the US, when you drive out of some of the hospitals, on the roadside, you find some billboards with a very prominent display saying that if you have visited a doctor, visit us. And this is a billboard from law firms. They don't even mention that if you have visited a doctor, if you're unhappy, you visit us. Doesn't matter, you visit a doctor, you visit us, we know how to extract money from them. In good old days, biblical time, there was a code of Hammurabi. If a doctor operated on the eye, and if the patient lost the eyesight, they removed the eye of a doctor. If the patient lost his arm, they chopped off the surgeon's arm. It is very effective. But in the end, there will be very few doctors left with the arm and the eye. Why we are vulnerable? We are vulnerable because in good old days, lawyers in this country were very busy fighting the land disputes because there was no document to prove who owns the land. With the digital recording of the land boundaries, that main source of revenue has disappeared for the lawyers. They're all looking for another client, another victim. And do you know who that victim is going to be? It's going to be all of you. The other tsunami which is going to hit all of you is about a private bill which is being tabled or which can be tabled in the Rajya Sabha by one of the prominent MPs about regulating the doctor's fees. You can read that bill in the Rajya Sabha noting in the internet. The whole bill is aimed at fixing the doctor's fees, but it will not stop with the doctor's fees. Soon it will encroach on government deciding how much an appendicectomy or a gallbladder surgery should cost. Now most of you will be thinking, how is it possible for the government to decide on how much a surgeon or a hospital should charge? It is possible because who is fixing the price of the drugs? It is the government. It doesn't matter what the pharmaceutical company says, the price of the drug is fixed by the government. And if we do not take proactive steps, if we do not work with the government, soon we will be on the wrong side and we can be in trouble. And if this bill is tabled, do you think any of the MPs or MLAs will object to it? I can tell you that this bill, if it is tabled, it will sail through. What is the problem of our industry? The biggest problem is the quality. Quality of healthcare across the country, whether it's a government hospital or a private hospital, is suffering. It is suffering because hospitals are not safe places for the patients anymore. Forget about Indian hospital. Look at US hospitals. If 200 patients gets admitted to an American hospital today, 1 in 200 patients die due to medical error. It is not medical negligence. American hospitals are some of the safest hospitals on the planet. But getting admitted to an American hospital is 10 times riskier than skydiving. Why? Because we haven't been able to put the process in place. We don't have that many people to take care of the patient the way they should be taken care 24 hours. Why? In India, it is primarily because we have super specialists and there are patients, and there is nothing in between. Super specialists do fantastic operation, they go home, 12 o'clock at night, there is no one to take care of the patient. Why? Because we have artificial shortage. Can you just switch it off, please? Yeah. We have artificial shortage of post-graduation seats. There is no one to take care of the patient. US has 19,000 undergraduation seats and 32,000 PG seats. We have 50,000 undergraduation seats and only 14,000 PG seats. Generally, a young doctor after his internship spends 3 years to 5 years in attending coaching classes in Kerala or Kota, trying to mug the MCQs and get one of those PG seats. There are no junior doctors available in this country because 1.5 lakh to 2 lakh doctors are out of circulation. They are spending 3 years to 5 years away from the patient. Why we have created the artificial shortage? We have created the artificial shortage because then the value of the PG seats can go up like how De Beers are controlling the value of diamond. We are creating the artificial shortage of PG seats to artificially keep the value of the PG seats high. And is anything happening about it? Nothing. Is the civil society bothered about it? Nothing. Because people who can raise their voice, they know how to take care of themselves. Can you just, it's got stuck. Can somebody move this? Yeah. This is the problem of this country, where our country is famous for putting the first world regulatory structure with the third world infrastructure. We have, this is the famous case, a anesthetist who has been practicing anesthesia in Bombay for more than 20 years. Unfortunately, he didn't have MD or a diploma in anesthesia. He gave anesthesia to the patient, and unfortunately, patient died for whatever reason, certainly not due to anesthesia. And the patient sued the doctor, patient's family, and Supreme Court called the doctor, who has no post-graduation qualification, as a quack. 20 years ago, MBBS doctors with experience could do hysterectomy, give anesthesia, do all sort of things. Today, if you do not have a PG degree, you cannot do anything what a housewife can't do. Having an MBBS doctor, we are reduced to the level of a housewife skills. We are not allowed to give anesthesia or resuscitate a patient, treat status asthmaticus or diabetic ketoacidosis because we are not licensed. Now look at the status of healthcare in this country. Top 10 causes of death in India. Other than the diarrheal diseases, every disease, if we have to treat, you have to have a post-graduation degree. The law made it mandatory. And then we don't have that many PGCs who produce this medical specialist. This is the Bureau of Labor Statistics data from US. Out of the 20 fastest growing occupations in US, 15 are in healthcare. And none of those 15 training programs exist in the country. Why? Because we doctors do not want to give the power to anyone other than the one who holds a title of MBBS to touch the patient. This is the only country where a nurse who has worked in the ICU for 20 years is not legally allowed to give an injection without the presence of a doctor. Forget about having nurse anesthetists and nurse practitioners. We have taken all the responsibility on ourselves, but we are not with the patient at 12 o'clock at night. So in the process, is a patient safe at the hospital? He is not. Now, who's going to address this? It is very important that we take stock of the situation and we address it before the regulation clamps down on us and forces us to change. In the end, I just want to let you know, in the end, I just want to talk about the evolution of healthcare in the last 25 years. 25 years ago, we in private sector were privileged because patient came, he had the operation, and he paid directly. Today, there are a lot of intermediaries have appeared. 10 years ago, the hospitals in this state got together. We wanted to help the poor people. So we convinced the government to launch a health insurance called Yashaswini Micro Health Insurance, because we thought we can do the procedure at cost price. And this is how the revolution of micro health insurance was born in this country. And we were paid 80,000 rupees for a heart operation 10 years ago. Now, 10 years later, we are still being paid 80,000 rupees. Everything has changed. The policymakers are now beginning to realize that the private sector makes tons of money, and the best way to regulate their price is to run hundreds of schemes and pay them as less as possible. Now, a lot of the hospitals in this country believe that if the government scheme doesn't pay us enough, let's not treat those patients. But I can tell you that it's a matter of time before every patient of yours will be having one type of scheme or other. It is very important we convince the government and work together with the government to convince them that cost of quality healthcare is expensive and we have to be compensated. If we don't work together, if we feel that if one hospital doesn't treat the patient, all their clients will come to me, in the end, all of us will land in trouble. Essentially, I would like to give a message to Dr. Gupta that, Dr. Gupta, we, the health sector of this country, can prove to the world that India can become the first country in the world to dissociate healthcare from affluence. We can prove to the world that the wealth of the nation really has no relationship to the quality of healthcare its citizens can enjoy. And believe me, we don't need any overseas investment. We don't need any grant and donation from US. We just need right policies. All we need is right policies. We will change the way healthcare is delivered in this country. Thank you very much for this opportunity. God bless.